Good morning. This is Bob from Meducate Academy, and I'm here with a good friend and senior associate clinical educator working for Meducate, Mark Reynolds. You may have seen him before on some of the YouTube channels we have, or even worked with him if you're lucky enough. Morning, Mark.
Good morning, Bob. How are you
I'm
today?
very well. I'm very well. I see you sitting there in your
Good man.
study with your vast array of books and
Yes, I see.
DVDs.
I see you're sitting in your study with your vast array of books.
Yes, I have, as you can see. Yeah. It's good to be informed, and actually, that's what I think the whole thing today I want to talk to you about information and being
Mhm,
informed.
mhm.
A nice little segue there, I think you'll find. Um, I have done this before. So I get what I do is I get a lot of interest from people at various institutions, universities, who will say things like, "Oh, we already use ACEs." And you've probably heard me talk about this, Mark.
Mm.
And I'm constantly having to explain the difference between an ACE, an associate clinical educator, and in some cases volunteers, simulated patients, and of course medical role players. Now,
When you talk to these people, then, Bob, does it turn out they're not using ACEs at all?
no, no, and I think they think they're using an ACE,
They
but what
think they
they're
are.
using, yeah, they're using an ill-informed medical role player, possibly somebody who
Mhm,
has a little bit of an understanding of what medicine's about,
mhm,
but their main job is to be an actor,
mm, mm.
not to be a medical role player. There's very few of those about. Whereas
Yeah.
with the aces, what I've found with the aces is, yes, some of them have been actors, and one or two of them still are actors. But when they have got themselves involved in the ACE program, as it were, all take ownership of it. It
Mm.
becomes almost like a second job to them
Yeah. Yeah.
and take it
Yeah.
very seriously. You very
Yeah.
rarely get that with medical role players. They take the
Mm.
job seriously when they're doing
Mhm,
it because they're
mhm,
professionals, they're actors,
mhm.
uh, but
It's
they,
a day's work.
they don't take it any further.
Yeah.
And
It's
that's
a day's
fine.
work. Yeah.
Say
Yeah.
again?
It's a day's work for
It's
them,
a
and that's
day's
fine
work. Yeah, yeah.
because
And that's how I started. That's how
yeah.
I started. It
Yeah.
was an opportunity to make a bit of extra cash as an
Mhm,
actor.
yeah.
Um, but I found the technical aspects of medical role play very interesting. The
Mm,
communication skills, giving feedback in an appropriate manner, objectively, and then my interests in the technical aspects of the examination, for example, cardiovascular, gastrointestinal, respiratory, also interested me as well. In a previous life, I've been an engineer, and so I'm interested in any technical details. But anyway, that let's go back a little bit. I think so. That's the experience I've had. People think they're using an ACE, but they don't
and
fully understand what an ACE does. In many
yeah.
cases, they've been using volunteers,
Mm.
and I think volunteers play a vital role in helping students. But it's a bit like the blind leading the blind.
Yeah,
Uh,
but don't forget one of the skills that even an ace needs is to play a naive patient quite often.
oh, absolutely.
Uh,
So
and
yeah,
you get that beautifully, from volunteers or simulated patients. And one of the things I always find a challenge, and I'm sure you do too, is when we're asked to play the naive patient, particularly in examinations, OSCEs, where we don't know what's happening, is then burying all of our experience and knowledge and then just, doing what we're told to do. And if they get it wrong, God bless them, we have to join in,
yeah, yeah, and I
and get
think.
it wrong with them.
But isn't that the strength of the ACE? That we can play a naive patient
Yeah,
whilst we're being examined. Then at the end of the naive session,
yeah.
where we're just a patient,
With
we can
feedback,
then
what
say,
went wrong?
okay, what
Mm,
what went wrong there? What did you
mm,
do
mm,
well,
mm.
and how can we improve any of the mistakes you may have made, or or add the things you missed, and why is it important to include
Yeah,
those
yeah.
as part of the technique? One of the one of the first things I learned was teaching students how to do percussion, just simple things like percussion. And I'd often spend 10-15 minutes taking them to one side and go, let's go through percussion again, just to practice the technique. Because
Mm.
a lot of the time, the academics don't have the time
No,
to,
which is
to
reasonable.
spend 15 minutes teaching somebody how to tap their finger. Something
Yeah.
they've done all their lives. And sometimes, and I do it as well, take for granted.
Mm.
You think,
Mm.
well, it's easy. Well, it's not if you've never done it. It's not
No.
easy to use a stethoscope unless someone's taught you.
Mm.
And some of these simple things well, are vital to the safe practice of a clinician, a
Yeah,
student.
absolutely. Yeah, yeah. So
So,
no, I think another thing about volunteers that's useful is quite often the demography of their age.
yeah,
Because
yeah,
obviously, for obvious reasons, many people who volunteer are retired because they're giving their time post-professionally.
yeah.
And the fact they are older people is a useful thing, I think, for students, particularly with some of the pathologies they're given. It's quite realistic, isn't it?
Oh, yeah. I mean, some of the volunteers I work with do actually have the pathologies that are required by the clinician,
Mm,
which can be a bit uncomfortable for the volunteer,
indeed.
particularly if it's something like musculoskeletal.
Yeah, yeah,
But it's useful for students to see real patients, real
yeah,
in
yeah.
inverted commas, patients who can be examined for half a day, say, on
Mm,
a particular body system.
yeah.
People presenting with AF, they can actually hear it, they can actually feel it in the pulse. They go,
But
wow,
do you remember how cross that our lead professor was when my AF was cured?
oh yeah, yeah, that's right, yeah,
I was an AF sufferer back in 2013, 14, and the
that's
professor in
right.
charge of the course at the time said, "Oh, Mark, what a pity you've been cured," he said. Such good teaching for the patients when he went into paroxysmal atrial fibrillation. And I
Yeah,
said, "That's fine." I said, "I'll just have a stroke, to teach the students."
yeah.
But no, and funny enough, it never happened. But actually, you talk about that. I was in Oski last week or the week before, and although I'm cured of AF, I still get ectopic heartbeats, which I take a calcium channel blocker for. And one of them came along in the teaching session, and it was
Right.
very useful. The student found it, and they said, "Oh, what's that?" And I explained, and it was a useful learning outcome for them. So I still pull out a bit of cardiac stuff out the hat sometimes.
On cue.
On cue.
Almost a professional. Well, as you know, Mark, I've got some MSK problems with my
Have
hip
you, Bob? I didn't know about that.
and my hip, and I'm waiting for a hip replacement. So the students
This is true.
actually get to see Trendelenburg Gate. They
Yeah, yeah.
actually get to see why I have to externally rotate the leg. I can't
Mm,
internally rotate, and it becomes obvious to them. And and you see them take a little bit more care as well when they're
yes.
examining me because they see that I'm in pain and it's
Yeah.
genuine. And
Isn't that the way, though? Yeah. I mean, as learners, they're so kind to us. And when you're examined by a seasoned pro medic, the things they do to you,
oh
incredible,
yeah,
really.
yeah,
Remember one, because I've had knee surgery myself, I remember one registrar blotting my left kneecap without telling me he was going to do it.
yeah,
And I felt like James Bond strapped to the chair in Casino Royale.
yeah.
Incredible, really.
I've been in
Um,
that position with a clinician that we know, with my hip and knee as well. Yeah,
mm. And they just have that confidence to carry on doing the examination without worrying about it. So, yeah,
and of course it's important for them to do that to find out what's actually going on. So, you know,
absolutely. They
yeah,
have to. And I
yeah.
think the learning students struggle with this fact that sometimes they've got to cause a bit of discomfort to the patient to get a diagnosis. They struggle with that. And once again, we can help them through that hurdle, really.
And that's it. We do. We guide them and say, don't be afraid
Mm.
of causing a small amount of pain. Obviously, if the patient's screaming in agony,
Yeah.
you can
About
stop.
to faint. Yeah.
But
Yeah.
if you cause discomfort, particularly with MSK exams, you need to find out
Yeah.
where that pain's coming from. And
Absolutely.
yeah, and it's giving them a confidence to take that, like you said, that extra step.
Yeah.
So,
So these places that you say they're using ACEs and they're not,
hmm,
what have they actually got then? Have they got simulated patients?
well, some of them are using volunteers, purely simple
Right.
volunteers, people they
Mm.
bring in. Some of
Okay.
them have used drama departments, so young actors who are partway through their apprenticeship, as it were, to do a
Hmm.
bit of history taking and medical
Hmm.
role play. So they have no communication skills per se,
No. No.
and particularly not medical. Certainly not
Mhm.
medical. That's something that I have to make clear when I speak to these people. A
Mm.
medical role player is very different to a role player. If you've just been doing role playing for a legal company or a corporate business or a prison service, it's very different in medicine. It's a very
Mm.
different animal. The
Hmm.
approach is very different, and the way you give feedback is gonna highlight those differences as well.
Yeah.
So they're using those, and they're occasionally using people who have pathologies,
Right.
which
Which is a
must be
great.
uncomfortable. Must be uncomfortable for the person.
Yeah. Yeah.
Particularly if they're presenting with abdominal pain, and they go, "Oh yeah, you've got you've got a kidney problem. Oh, can you come in and and somebody's blotting their kidneys all day.
Mm.
It's not going to be particularly pleasant. So
No,
yeah,
no.
so there's a misunderstanding of the term ACE, and I don't know how these people have heard of it, because the term originated from Professor Pal, Jim
Yeah,
Pal,
yeah,
who
yeah,
trained us
yeah.
um, over 14, 15 years ago, if not
Hmm.
more. And it was his term. And he was quite clear about what the role and responsibilities of the ACE actually were. And as he quite, he respectfully says to me, you've taken it a lot further than I ever thought it was going to go.
Mm.
Um, yeah, which was my intention anyway. I wanted to ensure that people were of a high enough standard, able to give relevant feedback. And I say relevant feedback, and I'm sure you've got something to say about the type of feedback an ACE would give.
Yeah, yeah. Well, it has changed. I mean, really, because I mean, Jim's original thought for the ACE was, for example, in an abdominal exam, you'd say to the learner whether they were palpating their abdomen, oh, that's too hard, that's too painful, that kind of thing. But we've taken it on to the next level, whereby, because we know the body system examinations in their correct manner,
Entirely.
yeah, how they carried out correctly, then we can point out the more technical aspects of it. I think that's what Jim wasn't expecting,
Mm,
for us to point out when technical things go wrong and can
yeah.
be cured. Because
Well, I
originally it
think,
was just about that hurts, that's not
yeah,
deep enough, you're not listening well enough. But we've taken it to a whole new level, really,
yeah, and
which is encouraged and
oh, he's
endorsed.
encouraged, absolutely. And I
Yeah,
mean,
yeah,
he's obviously involved with this idea that we've had of accreditation and
yeah,
certification
yeah,
of the role,
yeah.
which is an
I,
ongoing process. It's going to
I
take
think
time.
particularly as lay people, we need that. We need to hold up a piece of paper and say, this is what I am, this is what I do. Because as lay people, I guess we have to be taken seriously.
Well, this is the thing, and I think that's part of the problem, isn't it? Because most clinicians and academics, their experience of working with simulated patients is that the people they're using have no medical knowledge at all. They
No.
simply are given a brief and then told to act the brief.
Yeah, yeah.
Um, Whereas what we do is, again, so far removed from what they're doing, is to make it indistinguishable. In fact, it's often the case that people will say to our ACEs, you and me included, have you trained as doctors? Have you trained as
Mm,
medics? Were you a nurse? Have you been
mm,
a paramedic? Well, no.
mm.
We don't diagnose problems. We can
No.
talk about and demonstrate pathologies, certain
Mm.
pathologies.
I think
And we,
because we're confident in the things we talk about, we do get mistaken for
mm,
clinicians.
mm.
Because to be honest, we're using language and concepts that the average person doesn't use.
Well, this is the other thing. I think ACEs have been, because of the intensity of the training and the amount of work we get, particularly at Chester, Wolverhampton, and of course the University of Birmingham with the ISU,
Mm,
you develop and learn the jargon.
mm,
So, which is very important, I think, when you're working with academics, particularly students, because
yeah.
this is the jargon the students have to learn.
Mm,
This is the jargon they have to use. There's, for example, I very rarely hear medical role players, volunteers, or simulated patients ever talk about using SBAR when they do a handover.
no, they won't.
They don't know about acronyms like ICE or
Yeah.
SPICE or any of
The ABCDE approach to a
the
patient.
ABC. A number of
Yeah.
role players have said, "What's that?"
Mm.
And you
And
explain
so
it. They
on,
go, but
and
but
so on.
yeah, but they don't need to, because
No.
they're not expected.
Yeah.
Whereas I think getting other institutions to understand where we're coming from is really important. Which is
It,
why I, we've both done this. We've gone off, and demonstrated our skills to a couple of different institutions over the
yeah.
past year or two.
I just want to talk about now, though, is where we draw the line, where we draw the line as lay people, as
Yeah,
associate educators, and where we draw the line is we don't discuss pathologies, we don't discuss why they're doing it.
no,
We get their technique right, but we don't ever talk about why they're doing it, or
yeah,
that thing. And that's where it ends.
yeah.
That's for the
That's what the
academic.
academics for, isn't it?
Yeah, yeah.
Yeah,
And it's it can be a grey area because sometimes you know, and you have to kind of stop yourself because I mean, at the end of the day, Bob, after what I've been in the job since 2008, it's
Mm,
14 years, and as we know, in medicine, common things occur commonly. And for
mm,
goodness sake, over the last 14 years, I've had every common thing that a middle-aged male can have. And you know, and you think, but I can't go there,
mm.
because it's not my job. Um, yeah.
And there's another part to our role as well, isn't there? And that's to help the students build confidence.
Oh, that's a huge part of it. That's a huge. I mean, look at what we do, particularly as the students come towards their examinations, how much support we give. I mean, I don't know about you, but I've done pro bono one-on-ones with a ton of students and
Yeah,
supported them, rung them up, done Zoom, met up with them,
yeah,
and helped them. And I think one of the reasons they gravitate towards us is because they never find us scary.
no,
And with the best will in the world, if they're being taught by their senior peers and academics, they do find them a bit, and that's that kind of distinction between teacher and pupil.
yeah.
But we blur the lines. I mean, I think of myself as a teacher because I do,
Mm.
but it's a bit of a blurred line, and
Well,
they do like they genuinely like us and they engage with us well, and then we can support them in ways I think that the academics sometimes can't.
mm,
And you've said this before. You've had students tell stuff to you that's probably stuff they're not sharing with anybody else.
quite personal stuff about
Yeah,
confidence, about about their level of confidence, their self-esteem,
yeah, yeah,
and
yeah.
we go somewhere to help with that because, as you say, with that sort of go-between,
We are.
a volunteer simulator patient role player, they finish their job and go home.
Yeah,
They're usually only with the student for a very limited amount of time, whereas we'll be with students all day.
yeah, for
You
sure.
know, examples at Chester, 3 hours in the morning and 3 hours in the afternoon, sometimes a little bit more, because sometimes
Mhm.
we stay on a little bit later
Yeah.
to talk to
And,
the students who lack confidence and
and
guide
sometimes we have lunch with them as well.
and have lunch with them. So
Yeah.
we get a different level of insight into what the student's actually looking for, which gives us
Yeah.
the opportunity to tailor the training to
Mm.
suit the student, which I think
Mhm.
is vital. Now, academics don't have the time to do that. They have to give information in a way that fits in with the curriculum, which
Yeah.
allows the student to pass the exam at the end of, the end of the semester, the end of the
Yeah. Yeah.
course.
Yeah.
Our job is to do a little bit more. I think, yeah, like you say, we blur the lines. But, we were called associate clinical educators for a
Mm.
reason. I think the clue's in the title.
It is.
And our job is to educate the students, from that middle position, if you like. As you
Mm.
say, not to discuss pathologies, not
No.
to discuss
No.
diagnostics.
I'm not going to be modest about it. So I'm going to say something that isn't modest. That I know for a fact because I've spoken to lots of clinical leads over the years, and their surveys for the physician associate students, what they like best about the course, we always come out sometimes on top or near the top.
Yeah, that's absolutely true.
And I find that fascinating because we are a cog in the wheel, but we seem to be a very important cog. And I'm not saying, and you would agree with me, I'm not saying that these students pass their exams because of me.
No, no,
They pass their exams partly because of some of the support I've given them.
that's right. And I think that's really important. The amount of work that the academics and the clinicians put in is immense. I mean, hours
Mm,
and hours of work, organisation, behind the scenes stuff that the students never see.
no, quite.
So they don't understand the pressures that the academics are under. They only think about the pressures they're under.
Mm,
And we sort of, like you say, we fit into the no man's land where we can say, well, look, we can support you with that. You don't need to worry the clinician with these thoughts. Speak to me and I'll help
mm,
you talk through it. And I've found, certainly with all of our ACEs at Meducate, because I vet them and you've helped me vet ACEs, we're looking for personalities. We're
mm.
looking for people who
Yeah.
are friendly, um, but are honest and will give an
Mm,
objective, constructive criticism of the student's performance,
yeah.
but support them.
Yeah.
And we always get bad students. There's always going to be one or two students who really struggle with the concepts and ideas for whatever reason, personal
Mm,
problems, or just the course just is so so complex that they find it, difficult to deal with all these ideas and concepts, and we're there to sort of help them as well.
Mm.
And again, a volunteer, a simulated patient, a medical role player, well, they finish their job and they go home.
Yeah.
I know, having worked as a medical role player, you give very limited feedback. You don't have time.
No, you don't.
You're working with a facilitator who's running the station, and I understand that completely. It's time sensitive. You've got to do, a small group of people. You do a communication skills session in a couple of hours, and then it's finished. You never see the students again. You might bump into them on campus, and they'll say, "Oh, I recognise you were one of the role players." That's it. Whereas, we'll turn up at an institution to teach, and the students know us intimately. It's like, Bob, Mark, Greg, Mike, wow, oh, glad you're here. And instantly you see their spirits lifted because they've had a bad week.
Yeah, yeah.
And,
yeah, true.
And I think today, just doing this little podcast, this little interview with you, gives us an opportunity to think about what we're doing and why we do it. Because I think certainly the ACEs that we have, they're driven. I've seen it. They're driven to learn, to be better, and to help the students, not just at the physical level of the exams, but also psychologically as well, to give them a little bit of bit of support.
Absolutely. That's a huge part.
Support.
So you were talking about simulated patients as well, and a simulated patient can be given a brief to present with something.
Yeah.
There's lots of things you can present with without actually having them.
That's right.
And they're useful, but they obviously, unlike us, won't be teaching or feeding back how well it was done. Yeah. But it gives the student and the learner a chance to work in a situation, in simulation, which will help them in the future. And this really was exemplified when I was taken out to Prato by Jim Powell in 2013, 14.
Oh, yeah.
And I was taken out as a simulated patient because he had me presenting with pancreatitis.
That's right.
Now, because pancreatitis is incredibly painful for the patient, it's a 10 out of 10 pain. Quite often they're so painful they can't move. And as Jim said, you can't let learners near somebody with real pancreatitis.
No.
But you can let them near somebody who's simulating a 10 out of 10 pain with acute pancreatitis, who's made up by a medical moulage expert like I was with the Great Turner syndrome on my flanks. And just having the experience of being somebody, in simulation who's terrified of the condition was very good learning. So if you get simulated patients who are very good at the simulation of what they've got, it's very good learning. And it's always that safety net, isn't it? It's always that, if the student falls off the tightrope, they bounce on the net and nobody gets hurt. And there's huge value in that.
Oh yeah.
Even without the extra bit that we do, the sort of the teaching and the feedback, there's still great value in the simulated patient because it gives the opportunity. And I mean, these 40 grand sim men are not clever enough to do that yet. They can do a lot.
Well, they're incredible bits of.
They're amazing things.
Yeah, but they're not real people. No,
they're not real people. So there we are. So having been a simulated patient at a sort of a high level, I can see the value in it.
Well, there's value in all of the different areas. It's what I wanted to make clear today was really a distinction between how different the ACE actually is. Highlight these differences, and I know
we're everything, aren't we? An ACE is a simulated patient and a medical role player, and what we do as well. An amalgamation, a gestalt organism of all the things, really, giving all of the value of the other people. And I've been a volunteer as well because I've given my time for students. Yeah. I'm sure you have too.
Yeah, of course we have.
And we've done a lot.
Yeah,
all together.
And it's I think also what comes across as well from the ACEs is they have a certain passion for what they're doing.
Oh, for sure. And you've got to really, because you need that to grow in the role. If you're not passionate for it, you're not going to learn your stuff. And as you and I know, that you've got to learn stuff on the job, and you've got to do your own reading as well if you want to be good, and make your own notes.
Yeah.
I've got extensive notes of things, and you still refer to them.
Oh yeah. I mean, my phone is full of notes. My the number of books I have on my shelves grow. With because I'm genuinely interested in being a better ACE to help the students, and develop and develop the other ACEs as well. And I mean,
Absolutely.
as one of the, you know, the senior ACE in the organisation, you know, you're a valuable resource in the amount of knowledge you have as well, and have gained in a number of different areas over the years. And we all have different skill sets, you know.
We do, and that's important as well. And
Mm.
thank you for saying that. But it's important. We all have different skill sets. It all comes together. I mean, there's obviously stuff that, you know, we need female ACEs for, which
That's
is
right.
fair. Yeah, we need everybody, and we need people as well. And we're getting that now as well. People of different ages. We're attracting younger people as ACEs, which is good.
Yeah. And
That's
different
excellent.
demographics, you know, it's
Yeah,
important to
absolutely.
represent society in its entirety, the
In,
diversity, and
that's
uh,
so important.
yeah, and
Getting
this is what Mediacare are striving to do. But it is
mm,
difficult. I'll be honest, it is difficult to get the right people for the job, uh,
yeah.
with the right set of skills, who are passionate about it.
And this comes back to what we're talking about today, which is understanding the role,
Mm,
really understanding the role.
that's right. And I
And that's
mean,
what we've been talking
yeah,
about.
yeah, it is. And I think when people come to me, you know, looking for work, medical role players or whatever, I have to be clear about what's expected of them
Mm,
in terms of their professionalism, their confidentiality,
mhm.
as well as their ability to learn new things constantly. You know, I'm always dipping out, as you've just mentioned. We're always dipping in and out of our notes. You know, I'm always dipping in and out of books. I'll check on YouTube videos, because that's the other thing. Different institutions have slightly different ways of, say, performing a clinical exam, such as a respiratory cardio. There's all variations, and I think
Yeah,
it's important for us to be able to know what hymn sheet the academics are singing from at that institution,
yeah,
and be able to adapt to suit, rather than saying, well, I was taught this way and
yeah.
that's the only way you're going to learn. And I've heard that, and I've seen that happen. And it's always nice to see our ACEs will often sit in the lecture that precedes the session we're going to do. So we can see exactly what the academics are expecting of us. And I think quite a lot of the academics are quite surprised when we do that. Oh, can I sit in the lecture? If you need to, well, I'd like to, if that's okay. And I've learned a lot from, you know, sitting in lectures.
First time I tried to do that, I was refused, you know, years ago. I don't think they took me seriously. Didn't take long before they did, but the first time I wasn't allowed to do that, funnily enough.
Strange, isn't it? But I think
Yeah,
times have
didn't get
changed
it.
now.
Yeah, they didn't get it.
Certainly in the Midlands and up in Chester, where the ACEs are being used, you know.
Oh, I mean, come on.
It's
In
strange that
Chester,
it hasn't expanded. It's strange that it hasn't expanded, isn't it?
if people came to see us in Chester, they would realise that we're just part of this team and we're all working together to give the best experience for the physician associate students, and they'd understand how it worked.
Yeah. Well,
We are.
I know there's clinicians who are actually doing their PhDs on this subject, on
Mm,
simulation, and
mm,
so at some point we'll have a statistical analysis of how effective the different approaches are.
good. It needs that, really.
Yeah,
It'll
yeah.
be very useful.
I look forward to. There's lots of research on simulation, but there's never been anything actually. And I've read a number of papers on simulation and
Mm,
role play, medical role play specifically, but none obviously have covered the area of the ACE, because it's an unknown quantity.
it is.
They think they know what the ACE is, but really they
Mhm.
don't. And
No, no.
I think it's important to fly the flag, particularly for the, you know, the people who've invested so much time in becoming an ACE.
Mm.
It does
But like
take.
you said, the clue is in the name, associate. So associate, we're part of the teaching team.
Yeah,
Clinical, we are given the clinical knowledge we need to do our job properly. Educator, we're teaching
yeah,
through playing patients,
yeah,
through running through examination techniques.
yeah,
It's the name just sums it all up, really.
yeah. And I think on that note, is it a note?
B flat,
No, just E. E flat,
E,
yeah.
E flat.
Often used in the blues, actually, in rock. But there you go. A
I'll bear
little,
that in
little
mind.
bit more information. So, Mark, I'd just like to thank you for giving up your time this morning.
Thank you.
It's always
My
fun,
pleasure.
and I'll be working with you fairly soon.
You will, sure, yeah.
um,
Inevitably.
And now I've got to go off and write a new blog post. So our lucky listeners, readers, viewers can have more information about what we're doing.
Great.
Okay, thanks very much, Mark.
Thank you.
And just for the people who are watching this on YouTube, if you look below in the information spot, you'll see contact details where we can be contacted. And if necessary, you can chat to us about what the role entails. And we can even come along and do a little workshop for you.